back in the courtroom. Welcome back, folks. I hope you had a good lunch. It's a beautiful day out there. I'm sure it'll rain this afternoon, but at least for the lunch hour, it was nice. At the end of the morning session, Dr. Woodcock was still on the witness stand, and Mr. King was in the middle of his direct examination. So, Dr. Woodcock, you may resume the witness stand. I remind you, sir, that you're still under oath, and Mr. King, you may continue with your direct examination.
Thank you, Your Honor. Welcome back, Doctor.
Thank you.
I think when we left off, we were going through some of the conversations that you had with Mr. Holmes during your initial visit with him on the 24th of July, 2012. And I was asking you about when these symptoms first showed up, and we were looking at page 5 of your notes, and you were talking about the significance of these thoughts coming up in middle school when he described them, and I was wondering if did you ask him how this anxiety manifested itself at that young age in middle school, or what impact it had on his life, or did you not get into that in depth of a conversation with him about that?
Yes, I didn't. I don't think I had to ask him a lot about that. He volunteered that the anxiety caused him not to want to speak to people, and I think I mentioned that he said that reading from my notes, he figured out that if he responded to people, he wouldn't appear strange, and so he sort of trained himself to speak to people in spite of his anxiety. So it did have a pretty dramatic effect, I think, on his social situation.
Did you explore with him at all his comment about about him appearing strange to other people at that point, or no?
No, I think he made it clear that what made him appear strange was that he wasn't responding to people and he wasn't interacting or talking to them.
And when he described this anxiety and this inability to communicate with other people, did he describe it as something that he enjoyed or something that was difficult and troubling to him?
It was very difficult and troubling to him, yes. And here he also noted that it had impacted his social relationships. So that was a distressing thing to him too.
Did he indicate whether or not the anxiety increased when he went to high school from middle school?
Yes, he indicated that it continued to increase basically throughout all this time, through middle school, high school, and then he indicated it increased again during his graduate school program.
Any details on how it affected his graduate school program?
Yes, he used the words, he said, reading from my notes, social atmosphere magnified, and he felt barraged, and that had to do with the ongoing interactions that were part of the graduate school curriculum, and so he felt barraged by the anxiety.
We were also talking about these homicidal, intrusive thoughts that he described that started occurring back when he was a schoolboy, and you were describing what the nature of that ideation is. Did he talk about a attempted suicide or something that happened regarding suicide?
Yes, he mentioned that at one point he had used cardboard to cut his wrists. He called that a parasuicide, and he identified that as a cry for help. And he said that the homicidal ideation had increased when he couldn't kill himself.
Your Honor, forgive me. I just want to make on the record again a request that when the witness is reading whole cloth from his notes, that he let the record reflect that he's doing that.
All right, Doctor, were you just reading from your notes?
I was paraphrasing from them.
Okay, all right, thank you. Please let us know when you read from your notes, okay?
Yes.
And I'll try to do that as well if I notice that you're actually reading from the notes, so I apologize for that. What did you make of, well, first of all, what do you make of somebody at that age even thinking about suicide? Is that psychiatrically significant?
It's very significant, yes. It's very unusual as well.
How so?
Well, it doesn't happen a lot, and when it happens, it indicates that there's a significant thing wrong. Looking back at the information that I had about that, I would have trouble coming up with a specific diagnosis for that. I think usually schizotypal personality disorder, for instance, might cover it, but we usually don't apply personality disorder diagnoses at that age. So it's a fairly unusual kind of thing, but it certainly can be characterized as social anxiety with difficulty with socialization, poor social skills, and associated intrusive suicidal and homicidal ideation. So that's really the characterization of it, and it probably would be considered by some people even at that age and with those degree of symptoms to represent a schizophrenia spectrum disorder, even at that age.
In describing these intrusive homicidal thoughts that were unwanted, did he talk about whether they were directed at specific individuals? Like, was it somebody that was around him in his life or at the time, or was it more of a generalized thing?
Yes, he again volunteered information about that. Reading from my notes, homicide against everybody or else the world, never against specific people, always impersonal. Standard teen nuclear bomb, unrealistic. He's talking about, those are from my notes, it's not verbatim. He's saying that he didn't have a specific plan to kill anyone, that he felt that this was a general urge or impulse to kill people at large.
Did he indicate, and I'm looking at the top of page 7, it looks like you asked him about having specific plans, and did he respond to that?
He mentioned several ideas which I thought were fantasies, and in other words, they were an idea but not a specific plan, and he actually characterized them as being fantasies. For instance, a nuclear bomb. He didn't have any access to a nuclear bomb, but he also mentioned guns and cars. But he didn't talk about specific plans.
Now, when he was working with Fenton and Feinstein, did you ask him about whether he told them about a plan?
I did ask him about that, but his response wasn't direct. And my notes say he said it was anxiety. They thought it was depression. So he wasn't really direct about that. It was my impression that he had not talked to them about a plan.
What did he say, if anything, about their recommendation that he take an antipsychotic medication?
He noted that they had recommended an antipsychotic, but that he thought that that would be the end of his educational future and his neuroscience career.
Did you point out that he, at that point, already quit school?
Well, no, I don't think we were into the specifics of when each of these things happened, but yes, that was one of the obvious sort of incongruities about the whole thing. Rather than take the antipsychotic and try to continue, he felt his symptoms had overwhelmed him and he stopped, really voluntarily, I think.
Is that illogical from a psychiatric standpoint?
I think it's very illogical. I think that, but that's with a sense of possibility and faith and hope that the antipsychotics may have helped him. He clearly didn't have that sense that they might have helped him.
Now, is a certain amount of ambivalence, can a certain amount of ambivalence be part of the psychotic process in terms of receiving treatment or help? Or
It's almost always a part of the psychotic process. It's very hard for people with these types of illnesses usually to voluntarily seek help and to participate fully in the help process. There's something about the illness that just resists this sort of intervention. And then I should add, there are sometimes reasons for that. I mean, these medications have side effects and they can dull spontaneity and intelligence. So these are not idle fears.
did you talk with him about whether he had discussed with anyone else about these homicidal thoughts? Shared these thoughts at all?
He did say that he had brought it up with his girlfriend. I believe that's in my notes in this interview, but that he was not explicit. He said also that he was really minimally explicit with the doctors.
Did he talk about Plan A, Plan B, and Plan C? And what were they if he did?
Yes, he mentioned these by this way of referring to it as Plan A and Plan B and Plan C. And he said that these were long-standing ideas that he'd had, and Plan A was to find a fix or cure for neurological impairment. He didn't say that that was specifically for him, but that was certainly the implication that he was providing, that because of his own difficulties, he would occupy himself, he would deal with these difficult feelings associated with the suicide and homicidal thoughts by trying to cure neurological disease. And Plan B would be, as he described, just the opposite, that he mentioned, for instance, biological weapons, but he's basically saying it would be killing a lot of people. And then Plan C, he just said what I did. And the line of reasoning was, I failed in Plan A when I left school, when I couldn't continue in school anymore. And then there was Plan B that I'd thought about, and then there was Plan C, which is what I did.
I think it's on page 9 of your notes that you ask him about depression, and I was referring to that out of place before. And so if you could just take a look at that and answer my question about what he indicated to you about depression prior to July of 2012.
Yes, I had asked him about feelings of depression through all this time, and reading from my notes, he said not the main issue. And then he talked about, my notes say, catatonic for days. And he described feelings of depression associated, that were very severe and were associated with a real struggle just to get out of bed. And he referred to that as catatonia. He said he would lie down and couldn't move, and he felt really exhausted midday. And he said that he tried to fit these episodes of not being able to move, of catatonia, into his lunch break so that they wouldn't interfere so much with his schedule. Reading from my notes, he said he didn't see it as a problem because he liked to rest. My notes also say sleeping once asleep okay, longer than it should. And he basically told me that associated with these periods of not being able to move or needing to rest, he was sleeping more. And he described all this in the context of feeling depressed. And these are things that can happen to people when they have a severe depression.
And that was what I was going to ask you, is did you take those as being symptoms of some kind of depression? And if so, was it a psychiatrically significant depression in your opinion, based on what you knew?
These were signs of depression. He identified this as the feeling state of depression. These are symptoms that often go along, or that sometimes go along with severe depression. And it was part and parcel of this whole illness. It wasn't a major part of it in that he was left with only the depressive symptoms and only being unable to function because of his bad depression. It seemed to be a phase of this illness that came and then wasn't as severe and didn't last too long. But it did seem that during this phase, these depressive symptoms were more prominent.
Now, for folks that suffer from a mood disorder, like bipolar or major depressive disorder, is there often a depressive side to it and a manic side to it as well, or am I getting that wrong?
That kind of up and down is characteristic of bipolar. It can occur to some degree in depression, but if it's very significant, if the upside is very significant, then it would usually be considered a form of bipolar illness or sometimes schizoaffective disorder.
And is that in part why your eventual tentative diagnosis was a schizoaffective disorder, because you saw a depressive component to this?
Yes, there were several things about his presentation which had major mood components. First of all, there was the long-standing anxiety, but in terms of his depression, he had stated that he had a bad reaction to the antidepressants that he had been given at the health center, and felt that made him more dysphoric and jittery. And when that happens, it's sometimes an indication of the diagnosis of what we call bipolar II disorder, an intolerance of antidepressants, particularly if somebody isn't receiving an antipsychotic medication at the same time. And then he had these depressive symptoms. He had the earlier, what he called parasuicide attempt. So there were pretty prominent affective features here, or mood features, which is why I thought that the diagnosis of schizoaffective disorder was more appropriate than schizophrenia. And
did he indicate with regard to the this mania, or what he described as resulting from the medication he was taking, did he indicate that he had started doing a bunch of things that he didn't normally do in his life during that period of time? I'm looking at the bottom of page 11. Looks like he says he felt the SSRI started the mania.
He did mention several things. My notes say spending spree, driving extremely fast. Things were in a super, and I didn't write down the rest of that. But yes, he did feel speeded up on the antidepressants. I say SSRI, that's a kind of antidepressant.
And just in terms, you said that it can happen to people who are taking an antidepressant who are not taking an antipsychotic medication. Is it your understanding that Mr. Holmes did not receive any antipsychotic medication until November of 2012?
Yes.
So when you saw him on the 24th, are you aware now of whether he was on any kind of antipsychotic medication at all?
I understood that he was not.
Is that kind of thing sound like a typical symptom of mania, things moving in super speed and a feeling of driving extremely fast, I think he said?
It certainly could have been. I don't have a lot of information about that, but I think the main point is that it was a bad reaction to the antidepressants, and it certainly had some manic features, which means that he had an illness which was somewhat unstable and probably was going to be hard to treat.
And have you subsequently been able to review the notebook that Mr. Holmes read and sent to his psychiatrist?
Yes.
And he writes in the notebook, which has been admitted at page, as People's Exhibit 341, and I'm reading from page 32, brief periods of invincibility. Actions are in hyperspeed. Developed in last 3 months. Occurs typically 3 or 4 days a week, lasting all day with possible interludes of catatonia. Does that sound consistent with what he was reporting to you in terms of his symptoms?
Yes.
He also writes in the notebook at page 33 about how he is tired most of the time. On page 32, how he has excessive fatigue and catatonia, as he describes it, developed recently, often lasts for 3 to 5 hours in the middle of the day. If present in the morning, and I know it isn't particularly bad, can goad myself to move by thinking, Bambi, get up, you must get up. Does that sound like similar to the description he gave you of the depressive type of symptoms he was experiencing?
Yes.
You asked him about some other symptoms that he had, and did he talk to you about headaches? And I'm looking at page 12 of your notes, that he'd been having headaches for years.
Yes.
And was that significant in your mind, or not so much, or?
It wasn't terribly significant. I explored it to some degree and didn't think that it probably indicated any serious associated cause of headaches, such as a brain tumor or something like that, that conceivably could explain both his headaches and his presentation. I think I thought that they were probably, the way he had described them, fairly benign, and probably tension headaches associated with the stress of his symptoms.
And that's why I asked the question, because as a neurologist, would you want to rule out possible non-psychiatric causes for these symptoms?
Yes, absolutely, and that was certainly one of the things that I considered in terms of the headaches themselves. On the balance of the strength of the evidence for a primary psychiatric illness and the strength of the evidence for a neurologic illness that was manifest by headaches, I didn't think a significant neurologic illness was likely.
Now, you were in the room this morning when we called the first witness, who was a nurse named Jason Frank from the jail. Is that right?
Yes.
And you heard Mr. Frank describe that his interactions with Mr. Holmes, although brief, were consistent, he said, with interactions from other inmates. How can it be, doctor, that you see him in the jail and you identify him as being extremely mentally ill and without a doubt psychotic at the time, and that's what your impression was, right?
Yes?
How can it be that you can see that, but Mr. Frank, who's a nurse, apparently doesn't see that? I mean, how can those concepts coexist?
Well, I think the first reason for that is this suppression of affect, the fact that Mr. Holmes was behaving in a very quiet, unemotional way. He was organized enough to give me all the information that he gave me, which was a very considerable amount of historical information that was in response to my questions and well organized. So his capacity to organize his thinking in that interview and in suppressing any emotional disruption in his behavior, and also in organizing his behavior and basic activities of daily living. He had those capacities. The point is that those are not mutually exclusive. They can be thought to be mutually exclusive. I suspect that if anyone had sat down and talked with Mr. Holmes in the same way that I did, and he had felt some motivation to tell them what he told me, they would have understood that there was something wrong with it.
So is it the case then that when you see somebody who's in this psychotic state, it may not be visibly apparent, but when you begin to talk in depth with them, the depth and the nature of the psychosis can reveal itself. Is that a fair statement?
What's the objection? Overruled. It's a follow-up to what he just said.
Yes, absolutely. You have to be able to interact with the person to find some information about what's going on inside to reach these conclusions if it's not superficially apparent. And here it was not superficially apparent.
And we've heard from witnesses that it wasn't superficially apparent to his classmates either, nor was it superficially apparent to people who saw him in public. It appears that Mr. Holmes was able to go to the store, to buy things, to continue to attend class, to have the ability of driving. Teach McGuire pointed out this morning that in that video he had the ability to stand on his bunk by himself without any assistance. Do these kind of normal day-to-day activities necessarily mean that someone, do they tell us anything really about how severely mentally ill somebody is or not?
No, they may not, and in this case they didn't. And the people who did respond to him, for instance, a classmate who told him that she thought he needed to see a psychiatrist, that needed help, that followed him revealing something about this.
So is it psychiatrically significant to you then that when he saw a psychiatrist and they started talking about these things in depth, that the psychiatrist felt that he was having psychotic level of thinking, despite the fact that no one else seemed to be able to see that?
I think that the psychiatrists were most concerned about the violence that he did reveal and the dangerousness. But even there, he was limited in what he shared. I think, as far as I could tell, he was really quite forthcoming when I saw him on the 24th of July.
Did Mr. Holmes report to you that he ever experienced any kind of hallucinations or things that were moving that he didn't have an explanation for? And I'm looking at page 10 of your notes.
He indicated several things. First of all, nothing was ever formed. So that is, he didn't see an object or he didn't see a person. He did say that he had seen some fleeting movements earlier in life, and that earlier in the spring he had seen some shadows on the wall. But I think that's all he referred to there. When I asked him about that. He also told me that he had sometimes heard a ringing in his ears, but he didn't indicate that he had heard voices.
Okay. Delusions. You said that the other thing that made you understand how psychotic he really was the delusions. And what is a delusion, sir?
A delusion is defined as a fixed false belief. It's almost always in the context of some mental illness. We all have false beliefs about a lot of things. But if the belief can't be altered by any kind of reason or feedback, then it can be defined as it can be called a delusion. Usually we can give people feedback and get them to change their mind if we give them enough evidence. Delusions are such that no matter how much evidence you give somebody, it sort of reinforces the delusion. If you give them enough contradictory evidence, they tend to enlarge the delusion to include that piece of information somehow or other, or they just ignore it. Delusions are one of the hallmarks of what we call psychosis. The other one is hallucinations in terms of the positive symptoms.
So if someone has delusions, are they by very definition psychotic?
The term can sometimes be used if someone has a relatively benign delusion. There again, technically that would be an example of a limited psychosis. That's where again the diagnosis becomes especially important, and the question is this person a relatively mild, has a relatively mild form of schizophrenia, or do they have a paranoid personality disorder or something like that?
And in your opinion, does Mr. Holmes have a mild form of a mental illness or not?
No. Neither his delusions nor the degree of his illness are mild.
And I want to talk more about these delusions in a minute. But first, I want to talk to you a little bit about, was there anything else about that interview on the 24th of July that you remember that I forgot to ask you about that you think it was significant in your mind in forming the conclusions that you did form?
I think I've touched on all the important points. There are certainly details, but I think I've touched on the important points.
And I think you've told us what your clinical impressions were about psychosis and other things. Did you form an initial impression or differential diagnosis as to what you thought a possible likely diagnosis might be?
Yes.
And is that possible to do with the limited amount of information you had?
Yes, in that he was very forthcoming. He gave me a great deal of information, and as I've tried to point out, the details of that information had a certain coherence, a relationship between them, which supported the conclusions that I felt I could reach at that time.
Is it important to start with the present symptomology and the descriptions that the patient is giving you and work from there? Is that how you conduct your clinical analysis?
That's almost always the way we do it. Sometimes people will come in and they'll have a lot of medical records which give us a lot of information that may be very determinative, of course. It may include diagnoses and things like that. But certainly in the clinical situation, we're always most concerned about what's going on right now, characterizing that, and doing whatever we need to do with that present situation.
And in the circumstance here, when you form this initial impression of a possible diagnosis, was that something that was concrete in your mind? Were you sure that that was the diagnosis, or was just your thoughts about what it might be preliminarily?
What I was sure about was that Mr. Holmes was mentally ill, that he had a very severe form of mental illness, that it that he had a severe form of psychosis. That limits the possibilities a great deal. I thought that it was unlikely that he had an organic cause, such as an intoxication or a brain tumor or encephalitis or something like that. Those would still be possibilities based upon things when I left, but they would be much, much less likely. So those were the things that I was quite convinced about. And the number one choice on my differential or the list of possible diagnoses was schizoaffective disorder.
And why is that?
Well, because he met all the cardinal features of schizoaffective disorder. He had a psychotic disorder. Its onset was fairly typical. The fact that he had had premonitory symptoms for so long was somewhat unusual, but again, those kinds of schizotypal symptoms are not uncommon. And he had significant affective symptoms. So I thought that diagnostic group or label would cover most of what we were talking about. There were some features that were somewhat unusual, but they were really sort of variations within that diagnosis.
And so is schizoaffective disorder, is it kind of schizophrenia plus a depressive disorder of some kind combined together? Is that correct?
That's one way to think about it. It has many of the same cardinal features as schizophrenia, but with more affective symptoms than are usually seen in schizophrenia. And it's a relative kind of thing because affective symptoms can be seen in schizophrenia, and it's not unusual, for instance, to see especially depression as part of schizophrenia.
And by affective symptoms, do you mean depression and mania and things that have to do with mood?
Yes.
Now, at that point in time, did you communicate what your initial impressions were to myself and the defense?
Yes.
And at that point in time, did you do anything else on the case? Was it your understanding that you were being asked to do anything else on the case at that point?
Nothing else on the case.
And when was it that your job changed? Was it shortly after that, or how much longer after that?
It was shortly after that. I closed the practice, I believe, in September, and then I joined the university on November 1st.
Did that affect your availability in terms of the amount of time you had to work on cases?
Well, it did eventually. I certainly, part of the plan was to spend less time doing medical legal consultation. Initially, as I was building up the program, it didn't have a huge impact, but more recently it has.
Did that change at some point? As this case progressed through time and different doctors did their evaluations, did there come a time that I came back to you and asked you if you had any time to work on this case anymore at all? And did that take place?
Yes.
When, do you remember about when that was that happened?
I believe it was in mid-2014.
Okay. And was it about that time that Dr. Reed was doing his examination?
I think he began his just after that, yes.
Okay. And at that point in time, and I don't want to tell you what I said, but did you, was it your understanding that your task or role may have then been expanded to include reviewing the other doctors' reports and opinions and the data that they provided as the basis for those opinions, and giving us your clinical impressions of what your thoughts were based upon your review of those materials?
Yes.
And was it also part of that, the parameters of this new involvement, that if you wanted to visit Mr. Holmes again to check in on him, that we could make that happen for you if that would be productive?
Eventually, it was my understanding that that was a possibility, but in 2014, the task really was to look at the other reports and the data, which was quite extensive, that they had looked at in preparation for their reports.
And were some of those materials not even available until November or December of 2014?
Yes, they've continued to be available, I guess.
And did you use the time that you had to try to review those materials as best your ability, considering all your other obligations to the university and the hospital and your full-time career there?
Yes.
Were you able to review the materials, generally speaking?
Yes.
Was it your understanding ever that you were the primary diagnosing or testifying psychiatrist on this case?
No.
And does that continue to this day?
Yes.
Is it your testimony that you have reviewed every single piece of information that pertains to this case, including the more than 100,000 pages of police reports and hundreds of hours of video and audio tape recordings?
No.
Did you, as the result of the review of the materials that you conducted, reach a point where you felt comfortable rendering other opinions about the case and about Mr. Holmes?
Yes.
And explain to us how that process unfolds. I mean, the other doctors have talked about the fact that you can keep interviewing someone and exploring something forever, but at some point there has to be a stopping point. Can you tell us what your approach was to this case at that point?
My approach in this case is really mirrors what I do in clinical practice, except with the exception that this is more extensive. There's more records involved. There are more medical records or medical reports from other doctors to review. So there's more material. But the general approach in clinical medicine is that you start, as we've talked about, with the present circumstance. You understand that in its larger context, and that allows a diagnostic formulation, prognostic formulation, what's going to happen in the future, a sense of causality, that is, what are the factors that have led to this clinical presentation. And it like in any area, I think, as you learn about an area and you become expert, you understand which pieces of information are most important, and those are the ones you seek out and you verify. Then other information has a lower level of significance, and you may, in this case, you have to sample it. I had to sample it. I can't look at all of it to see if there's something there that would bring me to a different conclusion, to think that there's something else going on. And then there are the issues of what else is important in this particular circumstance, which have to do with the issues here at trial, I think.
In the course of your review, did you review Mr. Holmes' notebook?
Yes.
Did you review some writings from Mr. Holmes that were seized that he'd written while he was in the jail?
Yes.
Did you review medical records from Mr. Holmes' treatment at Anschutz by Drs. Fenton and Feinstein?
Yes.
Did you review Arapahoe County Jail records, both medical and other records?
Yes.
Did you review a social history of Mr. Holmes' family prepared by my office?
Yes.
Now, you talked before about the significance of genetics and with regard to a schizophrenia spectrum disorder and the significance of a family history. In your review of the family history and the medical records of the family, did you discover that Mr. Holmes had a family history of mental illness in his family?
Yes.
And was that significant to you? And I'm anticipating you're going to say yes, based on what you said before, but if so, how was it significant?
It's significant in that it increases the likelihood that anyone with his genetic background could have this kind of an illness. Again, we can't predict in the exact likelihood in an individual case ahead of time. But with that family history and with the premonitory symptoms that had occurred back through middle school, Mr. Holmes was, just on those two facts alone, we know that his risk of developing this type of illness would have been very, very high. There's active research going on now trying to help us be much better in this process so that we can identify high-risk people and actually intervene earlier in the course to prevent the development of a full-blown illness. So that's the kind of significance we think about.
Is that some of the research that Dr. Gurr is doing?
I believe she has done some of that research, yes.
Now, in the review of those medical records, was it significant to you that both Mr. Holmes' grandfather on his paternal side and the grandfather on the maternal side were hospitalized due to psychiatric illnesses and were reported to be psychotic? Is that a significant aspect of that?
Yes.
And did you also receive information later that Mr. Holmes's aunt, the fraternal twin of his father, had been diagnosed with schizoaffective disorder and that had disabled her for the past 30 years or so of her life?
I knew she had that diagnosis. I don't recall the information about her disability.
Is it significant that the defendant's, Mr. Holmes' aunt, has been diagnosed for the past 30 years with the same disorder that you've diagnosed him with today and with the same disorder that Dr. Metzner has diagnosed him with?
Well, I certainly think it supports the diagnosis. I think this is a very strong family history. This is, frankly, one of the stronger family histories I've seen for a psychotic disorder, a schizophrenia spectrum disorder. So this is a very strong family history. And as I said, along with the premonitory symptoms, would place him at really high risk.
Now, did you review, in addition to the jail records and the other medical records, did you review the medical records from when Mr. Holmes was admitted to Denver Health Medical Center Hospital in November of 2012?
Yes.
And you've seen the videos, like, for example, one of the videos we showed the jury this morning.
Yes.
Any doubt in your mind that Mr. Holmes was psychotic at that time?
No, he was psychotic at that time.
And in your opinion, did the psychosis predate or begin earlier than any metabolic disturbance that he had due to not drinking enough or eating enough?
Yes, he was psychotic well before the time I saw him on July 24th. And that process had continued, but it became worse in November, necessitating the hospitalization.
Now, how is that? It would seem like, is the psychotic process fluid, or is it just progress in very concrete ways? How can it be that he was psychotic before and then he's psychotic in November, but he seems more ill in November? I mean, in November, he's engaging in all kinds of behaviors. The feces on himself, he's naked, he's incoherent, unable to communicate. And he certainly wasn't like that when you talked to him on the 24th of July, right?
That's correct.
How can we explain that?
Well, he was worse. It was the same illness. It was a different phase of the illness. When I saw him, he was compensating in a lot of ways. He was suppressing emotion, and he was using his considerable intellectual capacities to stay organized and and to present himself in an organized way. And he had the capacity to do that. So his illness had different manifestations, and it was a different degree of severity. Lapse, but the natural history of these illnesses is to progress, and they get worse. And fortunately today we have treatments that can change that progression, but before we had treatments available, people with this form of illness could be expected to progress and basically require hospitalization the rest of their lives.
Did you review the reports and data from Dr. Robert Hanlon, Dr. Thomas Gray, and Dr. Rose Manguso?
Yes.
And those were doctors that conducted psychological and neuropsychological testing?
Yes.
Did you find that the testing results to be significant or helpful in your diagnosis, or were they congruent or not? Or
Yes, I thought that they were congruent. They were helpful. I don't think that they're sort of the core of the evaluation process, but they're not meant to be. They're meant to be specific and supplementary, and I thought that they were helpful, but entirely congruent.
now, at some point, or at various points, Mr. Holmes makes reference to two selves, or having two parts of himself. Did you consider a diagnosis of a dissociative identity disorder, a multiple personality disorder, in your differential?
I did consider that, but it not for long. I didn't think that it would be a central part of his diagnosis. There were many features that would not be consistent with that. So if he had had something like that, it wouldn't have been only that. And I didn't take his sort of poetic description in a literal sense.
Now, did he ever tell you that he felt like he was controlled by a higher power, possessed by a higher power, or something along those lines?
No, he didn't refer to any being or power or God or devil or anything like that.
Was there a component to his delusional framework, though, that involved a loss of control on his part, where he felt like he was being compelled or commanded to behave in certain ways or think in certain ways?
Yes, he felt that his thoughts had power over him. So it wasn't sort of a personalization, but he felt that the thought itself and that responding to the thought. So one of his delusions was that if he said what he planned to do, that he would have to do it. And that's one of the reasons why he didn't want to say it, because then he felt he would have to act it out. He wouldn't have any choice about that. And then when he did even allude to this, to the doctors and to a friend, that process actually became, that delusional process became even stronger. And so then he felt he had to begin acting on this. And then he told me that he felt that just sort of took over and he was going with the flow of this delusional compulsion.
Now, Mr. Holmes is an intelligent person, right?
Yes.
How can an intelligent person think that their thoughts have control over them?
Intelligence has nothing to do with it. This is a disease process which is independent of intelligence. It can happen to very intelligent people. It can happen to people of very low intelligence. Intelligence just doesn't have anything to do with it. This is a completely different disease process. Now, intelligence can sometimes be helpful to people be in the sense that they can develop coping strategies. And I think that we see that with Mr. Holmes. he developed pretty complex coping strategies that he used for many years in dealing with these thoughts. But in the spring of 2012, the disease process became much stronger, much more significant, and he wasn't able to cope in the same way in dealing with those thoughts.
And have you reviewed the text message from his classmate Hillary Allen, where he indicates that the floodgates are now open?
Yes.
Is that reflective of that in that conversation he says, she asks him, is your dysphoric mania, as you describe it, manageable? And he says, it used to be, but not anymore. The floodgates are open now. Was that significant in that regard to you?
Yes, I think he was self-observant enough to be able to put into words that sense that the floodgates were open and he was going with the flow and there wasn't much he could do about it.
Now, if he had enough self-awareness to be aware of that, why didn't he have enough self-awareness to stop the process? Well,
that has to do with the severity of the illness and the complexity of his delusional system and the different delusions he had. He had the delusion that that killing people would protect him from himself, would protect him from his suicidal ideation and from his depression, which by this time was very uncomfortable for him also. And he had this delusion that killing people would increase his own worth. And he held on to these delusions in the sense, as he expressed it to me, if he got treated, he wouldn't be able to get rid of these awful feelings because that wouldn't be an option anymore. And again, that was delusional, but that was part of his system, and his delusions were pushing him in this direction of acting out the delusions themselves. And the delusions were telling him that was the only way he could sort of rescue himself from all these terrible things he was feeling. So it was a combination of these delusions which were interconnected and which were compelling him not only to do these bad things, but also not to seek help. And that is not terribly uncharacteristic of psychotic disorders. Sometimes it can be very, very hard to capture people into treatment that can be helpful to them.
And that's difficult because, if you'll forgive me, that just doesn't make any sense.
It's a characteristic of the illness. It doesn't make sense. Nature doesn't always make sense. I often remind patients who are struggling with this sort of thing that if they had pneumonia and had the same mindset, they would die of the pneumonia because they would never seek treatment. And people do die of pneumonia if they don't seek treatment sometimes. And so there are analogies in medicine which can be really quite tragic, but this is a very common characteristic of psychotic illnesses. And very often the urge to resist treatment is wrapped up in some part of their delusional system.
For someone who is laboring under such delusions, I mean, that just seems so crazy to me. Does it appear that way to somebody who is suffering from the psychosis? In other words, does it seem logical to them?
That's variable. It varies on the person, and very often it varies on the stage of the illness, the intensity of the symptoms, and whether or not they're receiving treatment. So there can certainly be insight that this is crazy. People will refer to their feelings and to these conflicting ideas that they have and conflicting emotions as crazy. So there usually is some insight into it, but that doesn't mean that the delusions go away just because they have some insight that it's crazy. They still have the belief, they still are convinced that the delusion is true, and they still feel whatever compulsion the delusion may be associated with or the command hallucination.
Is there a danger in psychiatry to try to assign or attribute logical reasoning to somebody who is laboring under delusions and may not be thinking logically? Is there an inherent problem there?
Well, there's an inherent problem because the psychotic person, the delusional person, is not responding to, by definition, I mean, and we define it that way because this is what's happening. We can reason with the person, and it may not make any difference at all. Now, sometimes in those cases, people will say, and this is often how I approach it, well, let's just suppose that this medicine might help you. You don't have to agree with me, but let's do it as a trial. So sometimes people will take their medication on a trial basis. And sometimes they'll have a remission, they'll get a bit better, and they'll then be willing to take medications. And sometimes medications have to be started under involuntary circumstances.
Mr. Holmes talked about a need to keep it impersonal, the shootings. Does that have psychiatric significance?
Yes.
And what is it?
Well, it goes back to this, your reference before, to the two selves. There's I think, an underlying observing person in most of these situations. Sometimes that can be sort of completely obliterated by symptoms, but very often there's a struggle that goes on between these different kinds of impulses. There can be an awareness that they don't want to do this, but they still feel impelled to do it. So insight into this conflict doesn't mean that the delusions aren't there and that they're not strong. It just means that they have some residual insight.
So somebody who's suffering from a psychotic delusion may feel compelled to do something, or that something is the right thing to do despite the fact that they don't want to do it?
Sometimes, yes, or they feel that to some degree. The point is that they are ambivalent. They have more than one feeling at the same time, and they may put it as he did, that they feel like they have two selves. I mean, we say that I have two minds of something. You know, I mean, it's an extension of anyone's capacity to observe themselves and to be ambivalent, to feel more than one way about something at the same time. But in this process, there's this huge involuntary component that has to do with the psychotic process, the pathological psychotic process. This is not, of course, how the brain is supposed to work.
An involuntary process, you say?
Yes, it's not. It may not be within their control at all, and at certain times it certainly is not within their control. They can't will it away.
You've talked a few times here about the importance of, I'm going to start talking with you about sanity a little bit here and how you approach that analysis. But you've talked about the importance of diagnosis. Now, some psychiatrists may feel that when you're determining sanity, that the question of the diagnosis is really not that important. But what's really is important is specific facts which may or may not be consistent with someone who has the capacity to understand the difference between right or wrong. Do you agree with that, or do you think that it's fundamentally important to understand the diagnosis in order to be able to understand the thought process of the individual who's under the psychosis? If that makes any sense at all.
I do disagree with the approach of taking sort of a piecemeal, fact-by-fact approach. I think in psychiatry and in neuropsychiatry, it's very important to have a big picture in mind. All those little facts need to be able to fit in the right place. And if they don't fit in the right place, then you have to ask what is going on. And a diagnosis is, in a simplified way, a summary of what is going on. What is the problem here? And it should account for the vast majority of the facts. It may be that there are certain facts that are irrelevant to the diagnosis, and there's maybe certain facts that represent something other than that central diagnosis. And there may be more than one diagnosis. But when you understand the diagnosis, then that should be a place to hang all these facts, to make them coherent in an overall story, in an overall explanation. And I think sanity is an issue which absolutely requires that kind of understanding of the patient, because it's a very, very big question, and it's a very important question. And I think it has to be understood in the context of what is wrong with the patient. I mean, in Colorado, the first tenet, the first criteria for insanity is the person have a significant mental illness. So, as I said before, the first question that I addressed to myself when I first saw Mr. Holmes was, is he mentally ill? And then, is this a significant mental illness? Now, those are diagnostic questions. They don't hone in on the specific diagnosis, but they're still diagnostic category questions. But I also want to understand as much as I can about the specific psychiatric diagnosis. Under Colorado law, we exclude the diagnosis of antisocial personality disorder. So that has to be specifically excluded from the insanity criteria. So if one hasn't gone through that process, I don't think one can answer the question, at least the way I would approach it.
Let's talk real briefly about that, because I think the jury may have a couple questions about antisocial personality disorder. What is antisocial personality disorder?
Antisocial personality disorder is a pervasive pattern of behavior which involves ignoring the rules as they apply to you, to the individual, and ignoring the impact of your behavior on others. So people with antisocial personality disorder tend to be chronic rule breakers. They do not express empathy for other people. They don't evidence empathy for other people. And they may either be, their behavior may either be overt and they get into trouble with the law a lot, or they may be very sophisticated and they can be very successful in almost any line of work as long as they cover their tracks very well. But they're basically chronic rule breakers, and if you get to know a sociopath or an antisocial personality person, you learn very quickly you just can't trust them. One of the things that I've learned in treating people with antisocial personality disorder is that it's not that they don't understand the rules. They actually have a hypersensitivity to the rules, but the rules don't apply to them. The reason that I know that is that if I apply the rules to them, they get really angry. They don't like the rules to be applied to them. So there are these characteristics of antisocial personality disorder, and we're learning that this is often associated with brain changes that have to do with the perception of threat and with the capacity for what we call theory of mind, which is sort of the psychiatric term for empathy with other people. So these people have demonstrably decreased empathy. They can't get into your mind to see how you're feeling, and therefore they don't get bothered by how you're feeling in terms of their interactions with you. And they also don't tend to respond to things that cause other people anxiety. So they're able to sort of push through situations that would cause other people a lot of anxiety. And this results in a developmental pattern of behavior, which is usually quite maladaptive.
Is there any indication, according to you or any of the other psychiatrists involved, that Mr. Holmes has any of the symptoms or signs of antisocial personality disorder?
No, he does not meet that diagnostic
Is he a
category.
chronic rule breaker?
No.
To the contrary, was he, prior to this incident on the 20th of July 2012, was he a chronic rule follower?
Yes.
Any indication that he'd ever broken any laws or rules or harmed anybody?
I guess he hit his sister in a basketball game.
He hit his sister on the basketball court.
Yes. All right, you may proceed.
Thank you. Let me clarify that. Do you know whether he's never received a traffic ticket or a speeding ticket or a red light ticket or something like that?
I'm not aware that he has.
Okay. Are you aware of him ever committing a crime, hurting somebody, stealing things from people, those type of things?
Well, other than the incident, no.
Other than the incident. How about him being manipulative of other people and taking advantage of other people? Any indication of that happening?
No.
Any indication at all that Mr. Holmes has any psychopathic or sociopathic traits?
No, that's basically a synonym for this category.
Now, when we talk about the second part of the sanity definition, that being that the person is rendered incapable due to the mental disease or defect of either being able to have the capacity to form the required mental state of acting intentionally and after deliberation, or whether they are rendered incapable of having the capacity to distinguish between right or wrong. Let's talk about the right or wrong one first. This involves a moral component. Is that your understanding of what the test in Colorado is?
Yes, it's the moral component of being human. It's a central core, I think, of what makes us people. We can distinguish between right and wrong, and we can learn to modify our behavior.
Now, it may seem fundamental that killing is wrong from a moral standpoint, but that's not always the case, is it?
No, it's not always the case.
Is there kind of a continuum of different, the way morality applies to killing in different types of activities?
Well, I think most of us perceive that. There are people who believe that killing in war is all right. There are other people who are conscientious objectors. They don't believe in that. There are people who believe that it's okay for, if I'm on my nation's side, to participate in war, but it's not okay for the other nation to participate in war. And there are also examples of other kinds of, not necessarily killing, but illegal, against the law behaviors that different people feel are justified and some people feel are not justified.
Can you give us
morally.
Can you give us an example?
Nuns invading a nuclear warhead site because they're opposed to war. So they believe that the right thing to do is to disable or to protest the existence of the nuclear warhead. Other people might agree with them, but they might agree with the warhead issue, but they don't believe that they should invade federal property.
So in that circumstance, those nuns might feel that they might understand that they were doing something which was against the law, but feel that they were doing what was morally right.
Yes, that's certainly the basis of both nonviolent and violent civil disobedience.
And I posed this hypothetical to Dr. Metzner about, and you're an expert, so you're allowed to consider hypotheticals, about a terrorist as an example. And I asked him about the morality of that person killing, and how the majority of people in the world may think that that is morally wrong, but the group that individual belongs to, or the philosophy or ideology or motivation that person subscribes to, may indicate that it's the right thing to do, despite the fact that they're in the minority. Does that make any sense to you when we're considering this?
I think it's very analogous to the example of violence in war.
Now,
violence in war.
Which is what?
Well, where people feel that it's the right thing to do to use violent methods, including killing people, in order to protect our nation.
And the conscientious objector may disagree and think that it's morally wrong.
Yes.
So, and I think Dr. Metzner agreed with me on this, in order to analyze whether someone understands or has the capability of understanding that their conduct is morally right or wrong, do we not have to look at the way they perceive what everyone thinks and what is right and wrong and those kind of larger issues?
Your Honor, I'm going to object to the form of the question, and that's several now where we've dipped into past testimony that the witness is not he's relied upon for purposes of his opinion.
All right, I'll sustain it as to the form of the question. You may rephrase your question.
Sure. Is it important when we're analyzing sanity in this context from a societal moral view that we look at how the individual who's involved perceives morality and the societal moral view from their perspective?
I think it's a necessary part of the analysis, yes. Because insanity assumes that that perspective is distorted, is deficient because of the mental illness. So
And
if you don't understand that perspective, and I don't think you can understand that connection.
So then if we take, is there a danger in taking individual facts and applying them to the analysis without running them through the psychotic process that the individual may be engaging in their cognitive process?
That's certainly the way I approach it. I have a great deal of difficulty knowing what the significance of those individual facts is outside of the big picture. If they fit into the big picture that I've formulated with the diagnostic formulation and the pathological formulation, that is, what's going wrong with this person's thinking and behavior, if they fit in, they make sense to me. If they don't fit in, I don't really know what to do with them.
So is it important then that we understand the psychotic thinking process in order to understand whether the person was capable of distinguishing between right and wrong?
Well, I think it is, but I would make the distinction that psychosis, delusional thinking, is by its nature irrational. So we're going to have limitations in how much we can understand it. What we have to understand is the degree to which it is there and what we can about how it may drive behavior. What we don't understand, other than in the general sense that these are characteristics of a severe mental illness, we can't understand them, I think, completely in a logical formulation because they're by essence crazy. They're illogical. And in that sense, we have to transport ourselves from a completely logical, rational perspective and try to understand what's happening with someone who has this kind of twisted disorientation.
Are the rules of the psychotic process the same rules as the rules of logic which we apply in our normal lives?
Absolutely not. They sometimes have certain types of inner coherence, but there are no rules of logic to them. The term that we use in psychiatry is primary process. This is the kind of magical thinking or disconnected thinking or dream thinking that we see in children, for instance, or in our own dreams, but it's not a logical process.
Is it part of the goal of the mind to make a sense of reality that makes sense?
Most, I think, neuroscientists would say that that is the principal job of the brain. the brain doesn't do a very good job of adapting unless it comes up within the environment, unless it comes up with some sort of a workable model of what the environment is, and then learns how to manipulate the environment through that model. So the brain is always looking for a model of reality, an explanatory way to put all the, enough of the facts together to adapt, to get along, to survive. And one of the things that's painful and difficult or dysphoric in mental illness is that the logical connections, the cause effects, don't fit in the same way, and so it's very hard to come up with adaptive strategies.
Is this true no matter how repulsive or distasteful the conduct involved is?
Unfortunately, that's the case. Yes.
Mr. King, whenever you get to a good breaking point, let me know so that we can take our afternoon break.
I can do it right here, Your Honor.
Okay. All right, members of the jury, let's go ahead and take our afternoon break at this time. Please make sure you follow all the admonishments I've been giving you with respect to your conduct when you're not in the courtroom. Let's take 20 minutes. I'll see you back here at almost 3:30, a little bit before 3:30. Thank you. Please be seated, everyone. The record should reflect the jury has exited the courtroom now. Let's go ahead and take our break, and then we can chat after the break, okay? The court will be in recess. Thank you.
Please rise.